Okay, well, welcome everyone. I know there's going to be a few more people coming in, but thank you so much for being here. I know it's a beautiful day out in San Francisco, and so I appreciate you taking the time to come to this event. We're so happy to have Dr. Rojas here.
And thank you.
Yeah. My name's Naomi Hoffer. I'm the program manager at the Cancer Resource Center, which I think I know many of you have been there, but for those of you who haven't, we offer supportive care services and information and events like this, a lot of different programs. We're located down on the first floor, just right behind the gift shop. So you can check us out. You might be on our mailing list if you signed up for this via email. So I'd like to introduce our speaker today. Julio Rojas received his medical degree in Monterrey, Mexico. He completed his doctoral studies in neuroscience at the University of Texas and completed a neurology residency at UT Southwestern Medical Center in Dallas. He joined the UCSF Memory and Aging Center in 2014 as a behavioral neurology fellow. Dr. Rojas participates in patient evaluation and monitoring. He provides care to patients with various neurodegenerative disorders. He also collaborates in the evaluation of patients in the Alzheimer's Disease Research Center, the Frontotemporal Dementia Program Project, and the Rapidly Progressive Dementia Program. Dr. Rojas is interested in experimental neurotherapeutics, and his research focuses on biomarker development and cognitive enhancing interventions. Cognitive enhancing, I love that he's doing that. So please help me in welcoming Dr. Rojas.
Thank you. Thank you all for being here. As Naomi said, in a beautiful afternoon. Choose to be here, but I hope this is useful. So in the center, we focus on degenerative diseases, basically Alzheimer's disease and other sorts of diseases of advanced age. And we have noticed that cognitive symptoms or cognitive deficits not only come from dementia, related disorders or Alzheimer's disease, degenerative diseases, but also from a wide variety of conditions and insults. And one of them is the one that comes with cancer and cancer treatments. So we are becoming more interested in trying to study this and help out treating these symptoms and sorting out, differentiating what symptoms are due to the cancer treatments or the cancer itself versus age or versus other degenerative conditions. So it's very important to start with the concept that the brain is a very important organ, but it's driven by energy. Its function is driven by energy. It's a very sensitive, energy-sensitive organ. So if we skip a meal, if we have a high session of exercise, those things can impact the availability of energy supplied to the brain, and the brain can suffer from that. Most of the input that gets to the brain in terms of blood flow, oxygen, and nutrients is used to maintain the baseline function of the brain. And the brain is all the time processing information in space and time. And to maintain this baseline level of function, we need a constant supply of nutrients and oxygen, blood flow. So anything that affects this supply of the elements that the brain needs to keep the function can alter brain function. And there are a few elements that I'll mention in a second that impact how vulnerable the brain can be. But the brain is a fascinating piece. I define it as the most fascinating piece of organized matter in the whole known universe, and we all carry one of those. It's so fascinating because it's developed in a way that it allows us to interact with the environment and process, again, information in space and time. But it's the center where all these vital functions are regulated. Functions that are going on right now, we don't even think about them, but the heartbeat, the respiratory rate, how much we're sweating, the GI physiology, digestion, all those things are controlled by the brain, but also more relevant things to us, more salient things like how we interact with the environment, movement, how we approach things, how we feel and process things, how we perceive things, how we behave in front of people, There's a lot of computation going on in receiving cues from the environment and then reacting to them almost automatically. But all this is processed in the brain. We don't even know. We don't even think about it. But it's always happening. How we communicate, how we understand language, how we express our ideas, and then if we see a block on the road, how do we get around it and keep going? So problem solving, the brain is key for this. The brain also is the place that defines, or where our personality is defined, our dreams, our aspirations, our imagination, our feelings, our creativity. So it goes from very basic things to very complex and kind of almost amazing things, amazing functions that defines us as human beings. And again, all this is based on that concept that I mentioned at the beginning, that all this is driven by how the brain uses energy just to maintain the function. And the function is all these complex things. And I don't think we understand a lot of these functions. For example, a function that to me is fascinating is just the mere concept of consciousness, how we are aware of ourselves and our surroundings, and how we see each other, or how we see ourselves as part of something bigger. And this is all, this conception is there in the brain, and it can all be tracked down to, cells maintaining function based on, use of energy supplies or nutrients. And this is a graph I like, because I'm going to show you here on this part things that help to maintain cognition. We see cognition as this, scale or a balance, and we want that little brain to stay steady in cognition. We don't want it to move up or down. We need kind of a bulk of things that will support and make sure that the cognition stays stable. But there are other factors that will come in and try to push it around and stabilize it. And this is a kind of an operational way of understanding the brain function. One element that supports the brain function is how healthy we are in general. Mostly the cardiovascular system. How healthy our heart is, our blood vessels, our lungs, all those things that are important to get all that blood flow and the oxygen supply to the brain. The nutrients, what we eat, all these things support brain function. So if you see an outside that looks not very healthy, probably the brain will also not be very healthy. But here we're talking about medical conditions. The main ones that we care about are all those cardiovascular risk factors like hypertension, diabetes, cholesterol, lung disease. But definitely things like cancer can also alter this. Our genetic constitution is also very important. We know that a lot of the risk for cognitive variation, especially with age, is determined by our genes. And it's unfortunate because we don't have a lot of control on this. This is just, so far, this is how we understand it, and it's just the way it is. But we know that a lot of our vulnerability is predefined. And the gene risk is not only affecting the brain health, but also our general health. But this is important to take into account. There are things that we do throughout life that seem to have some protection. For example, you were mentioning that you work many years, and then you exercise for many years. Those are things that are in our control. But we know that certain things that are cognitively stimulating seem to convey certain protection. For example, 2 pieces of information from observational studies, and these are not interventions. These are just observations that are done over time on people. One of them is, for example, that a higher level of education seems to confer certain cognitive protection or cognitive reserve. So people with higher education seem to be less prone to developing cognitive decline with age. And the cutoff is 12 years of education. So if you completed high school, it's less likely that you will, comparatively to those who didn't finish high school, won't be as likely to have or develop cognitive complaints. And this is after they correct with all the things that come with more education, just like general health or your comorbidities and what environment did you have and how did you grow up. When they control for these things, there's still an effect of education. And we know now from research in the last decade that more education just seems to generate more pruning of neurons and more connections, more contact between neurons that facilitates the processing of information. And then other factors that are very important, and this is what you mentioned, the stress, the psychosocial environment. I don't think we understand really well how this operates and how this affects the function, but if you're in a nurturing environment, you are more likely to have a stable cognitive function, as opposed to having, family violence or living in a society where there's a lot of crime or violence. This is definitely something that in longitudinal studies, again, epidemiological studies, has shown an effect. So a more nurturing environment seems to be beneficial for the brain, especially during development. And then on the other side of the balance, we have elements that seem to make cognition decline. And one of them definitely is aging. We know from studies that we time cognition declines as a function of aging. That's part of normal aging. But to a certain degree, even though we can see a plot, after age 55 or 50, we can see a decline in the cognitive scores. There's a lot of variability. If you look at the bulk, the mean of all people that have been studied is kind of steady state decline. But there are people who, age really well, quote unquote, and they don't show any decline, or they are stable, or they improve a little bit. But the general trend is that there's a decline. And what defines who declines faster than other people, I think is a lot of this, but I think there's still a lot more to discover. But in general, yes, aging is associated with certain decline. But how do we know when the cognitive decline is just aging as opposed to something else? And I'll talk a little bit about that, because I think that's a key question, and I think we have to stop there and ask the question and look at the implications, because a lot of people may have normal aging, normal cognitive decline, and worry too much about it. They notice it, and it's part of normal aging, but they worry, and I think it's good to be reassured. But on the other hand, you may have a situation where people decline more than expected, and they just attribute it to age. And that's also a problem. If there's more decline that we could expect just from age, and we neglect that, that's not an ideal situation, because maybe that situation of a lot of decline that is just attributed to age is potentially reversible. So I think it's important to keep that in mind, that we could be on one or the other side. And then this effect of oxidative stress, just think of an apple. You bite an apple and you put it on the counter, and then you leave it there for a week or 2 weeks or 3 weeks. What's going to happen? It's gonna start rotting, right? That changes color, changes the texture, loses water, and it shrinks a little bit. That is a normal. As a consequence of living in this world, let's say, all the biological systems in our planet tend towards oxidation. So all things that have biomolecules, proteins, sugar, and fat, all those things tend to oxidize with time. That's just the nature of us living in this oxygen-rich environment. and that includes all the tissues in our body, the skin, our hair, the brain. All the molecules in the brain, the cells in the brain tend to oxidize. So the body has developed certain strategies to fight the oxidation, to keep a steady state function, a steady state level of the quality of the molecules in our body. But with time, even those systems also degenerate and become less efficient, and that's when this oxygen that we're breathing, 25 or 21% of oxygen, starts making a damage in the molecules, and then the function decays, and that brings about cognitive problems in our particular case. These are tied, very tied together. But oxidative stress can be accentuated by general medical conditions and our gene constitution. Psychosocial stress definitely can increase the actual biological stress that tissues bring about. There's this concept of the psychoimmunobiology, which is getting worries and getting your emotional system engaged triggers certain changes in your biology, your physiology, your immune system, that definitely contributes to this oxidative stress status that is aggravated, or is contributing, or is making worse something that is happening naturally. And then from something that is of interest to us is chemotherapy. So the drugs that we use to treat cancer, they don't necessarily cross and reach the brain. Some of them do, and some of them directly cause an effect. But a lot of this, the damage that chemotherapy has on the brain is through oxidative stress. It can cause damage in other organs, in the liver or in the blood, and those are major sources of oxidative stress that can affect cognitive function. But the story doesn't end there. It's not only the chemotherapy. We mentioned that things like radiation can also have an impact, and the cancer itself, the disease itself. So, for example, for radiation, we know that even if the radiation was to the chest, if it was not radiation directed to the head or the brain, as a bystander effect, the radiation to the chest can still have an effect on the biology of the brain. And this has to do, or is mediated by the oxidative stress mostly. And I think researchers are still understanding how this happens, but this is being demonstrated in animals, for example, where you radiate a leg of a rodent, and there are effects that they can see, the generation happening in the brain, even when the radiation was targeted to another organ. And the disease itself, so cancer produces direct and indirect effects on the brain, all again mediated by oxidative stress. Sometimes there are diseases that are triggered, immune diseases that are triggered by the cancer, and these are act by generating antibodies against your brain. That your body is trying to attack the cancer, but it comes up with a strategy or a response that not only attacks the cancer but also attacks cells in the brain, and that can cause severe changes in cognition and behavior. Those are very dramatic and not very common, but those sometimes happen. And then the other aspect of it is, if you are in a negative psychosocial environment, if you have cancer, but on top of that you're having family problems and financial problems, and you have all other sorts of stress, that all adds up, and that brings down your cognitive function. So, unfortunately, when we have a situation of cancer, it is a bad combo for the brain, really, for many different situations. Just the psychological stress of having the diagnosis of cancer and going through the stigma, and the biology of cancer itself, if it's a more aggressive type of cancer, if it's more advanced, that also adds up to the problems, the cognitive problems, and all the treatments that come after that, the complications, the medical complications. You may have, for example, radiation-induced vomiting and abdominal pain, and that by itself can also affect the brain function. So if we go back to the 50s or the 60s when they started using chemotherapy drugs, and they treated patients with these agents, and what they wanted to do is rescue people from dying, really. And how much cognition was affected, I don't think they were paying a lot of attention, because on a larger scale it was better to just survive as opposed to losing cognitive function or some concentration or having symptoms. I don't think they were paying attention. And the big problem was that for a long time they said, this patient was undergoing cancer, they received treatment, and then they have some cognitive problems, and they said, oh no, those cognitive problems, they're just stress. They're just have a cigarette, just chill out. You'll be fine. But with time, people started observing and being more methodical about, seeing what happens with cognition, and they realized, no, it's actually a real problem, and we have evidence at different levels, from epidemiological level to tissue, experiments in petri dishes where they have demonstrated that these things, cancer, radiation, and chemotherapy, and the stressors of cancer affect the biology of the brain and change cognition. So this is my diagram of a neuron. So the brain is the functional unit. Is the neurons. We have millions and millions of neurons, and what these cells do, they have this compartment that integrates information from signals that come from other parts. And we understand it now. The fashion has to think about the brain in terms of networks. So you have different nodes connected, and they exchange information. So in this part of the cell of the neuron, the information is integrated, and then the outputs are electrical signals. So there's electricity that comes out, and there's a signal that passes through a different cell through this release of chemicals over there, right? But the electricity travels long distances. Sometimes one of these connections can go from the surface of the brain all the way down to the toe. So it's a very long connection. Can be as long as that. And there are a few elements to see here. One of them is these green things here, what I call mitochondria. Those are compartments of the cell where energy is generated. So all the food and all the oxygen somehow are combined in these little compartments, and those elements are transformed into usable energy for the cell. The energy is used to maintain this electrical release, right? But these are key elements there, because if you're thinking of war terms, and if you're going after the enemy, you want to attack those areas where the energy is produced, right? You want to eliminate the enemy. That's one aspect of it. And then the other aspect of this mechanism is you have this myelin. This is a fatty sheet that surrounds the connections, these projections here. We call them axons, right? These projections. And the axons have these wraps of fatty tissue that allow, that facilitate the spread of the electrical signal. So, but myelin, this sheet, is also a key component here, and it's very susceptible to damage. And actually, you have the neurons, but you have also a system of cells supporting the neuron, cells that provide the myelin sheet, and cells that provide a nurturing environment, and all those elements around it are probably more active than what we knew in the past. Those cells of support regenerate, and they respond a lot to stress by releasing signals and by maintaining basically a nurturing environment. But these two elements here, I've highlighted, mitochondria and myelin, because they are very vulnerable to the effects of chemotherapy, radiation, and cancer. And by the way, if you're not, I'm referring to them as a trio: radiation, chemotherapy, and cancer. And I'm not just saying chemotherapy effects. I think all of them have a weight. All of them have probably the same impact. And that's why we don't, I tend not to call this chemo fog or chemo brain, because it's a misnomer. That means that we're just paying attention to the chemotherapy, and it's all of them. So you may think, or you may ask then, how do we measure, or how do we know when a cognitive change is due to age or radiation or the disease itself? And if you remember, I mentioned that diagram with all the functions of the brain that go from comportment and imagination and creativity. And it's very difficult to study all those functions, really. Those are too complex to reduce them to something that we can measure. So what has happened is that neuropsychologists have come with strategies to simplify measurements, and they come up with some tools that are not perfect by any means. They just give you a kind of a very partial view of the brain function. And all those functions that I mentioned before, they can be reduced to 4 or 5 domains that the neuropsychologists are able to study and analyze. And their tools are allow basically to compare between people and compare over time. And that's kind of the goal, to be able to track changes and to be able to compare to a reference. And then the other aspect of it is there's a simplification of all the functions of the brain. Things, like what I mentioned, the consciousness or attention. Those are kind of difficult things to measure and to quantify. But other things are what they call, or we would call, low-hanging fruit, easy to measure. So in the clinic, or then what neuropsychologists do is to measure 4 or 5 different domains, and one of them is memory. And it's difficult to translate what memory means on a day-to-day basis to what the actual test is going to be in the clinic. So they don't necessarily go hand in hand, but they do a fair job at allowing us to detect when there's a problem or a change from baseline. And also they allow us to classify people. So for example, we can tell just by doing this sort of test, we can differentiate between two different diseases just based on the pattern that we see on this test. So memory symptoms are things like forgetting, having problems learning. They tell you something and you have to keep asking, what's your name again? You really quickly forget the name, or you leave the room and then you realize you forget something, you left it behind. Or worse, even worse, you're driving, and you realize that 20 minutes ago, or you've been driving for 20 minutes and you realize you left something behind. You have problems remembering your appointments, when to take your medications, you miss family events. The sort of tests that you will see for memory are very artificial, but again, they give us a nice idea of what happens. For example, they might give you a list of words, and you have to memorize them, and then they give you several trials, and we track how many words you learn in each trial, and then they ask you to repeat the words 30 seconds later, and then 10 minutes later, as measures of recent memory and then delay in memory. Maybe they may show you a list of words and see if you can recognize some of those words. So that's kind of a variable memory test. But they can also show you a picture, and maybe there could be a scene, for example, and they tell you to pay attention to the picture. and then they ask you minutes later if you can recall how many flowers were there. But that's complex because it's not only testing your memory, but it's also testing your attention. Or they can give you a passage to read, and you have to basically go through it, and later on they ask you specific questions about what happened in the passage, basically to see if you can remember the elements of the passage. But again, that's complex because that's not only testing memory, but also your ability to communicate, your language. So some of these things overlap, but in general, we have two big ways of testing memory: verbal and visual. And another element which is very important is executive function. This one is very important, and executive function is a domain that is probably the one that contains the functions that are defining of us, of humans, the high order: attention, concentration, multitasking, problem solving, keeping information in the back of our mind to manipulate. And there are different elements of this, but this is a crucial one in cancer because this is the one that is especially vulnerable in cancer. As opposed to, for example, Alzheimer's disease, where initially people present with memory problems. So Alzheimer's disease will present here with forgetfulness and repeating the same question over and over. But this one has to do, again, with attention. And this attention issue has more connection with that example I gave before of, can you tell me your name again? And you're 2 minutes into the conversation, and can you tell me your name again? It has to do with this, like how do we take the information, how we sort the information, and then how we organize it, how we use it to solve problems, how we use it to improvise. And basically, executive function has to do with two main things. One is how we classify things in our mind, and then how fast we can come up with solutions and answers. And remember, talking in the computational terms, the processing speed, or how fast we come up with answers, is tightly connected with that electrical conduction that I showed you before in the neuron. So executive function is very important because one is very vulnerable to the cancer effects and the treatment effects, but also because executive function is tied to the other functions like memory, the one that I mentioned before. Executive function is also tied to other functions like language. And language here is you understand everything other people say. You can communicate your ideas. You don't stutter. You don't howl. You don't forget words. That's a common one, that you are talking and then you wanna, and then you have those kind of embarrassing moments when you forget and you don't want people to notice that you forgot that word or you forgot that name. But it has to do with language. A little bit overlaps with executive function sometimes. It could be more pure, for example, when you lose meaning of things. When they tell you sit on the chair and you say, what is chair? I don't know what chair means. The connection between the word chair and the meaning of chair is lost. So that could happen too, not in cancer, but that's a way we can tell. In cancer that never happens, right? But in certain diseases, that connection is lost. What can happen in cancer is, for example, that you have lapses where you forget the word that you want to say, and then 2 minutes later you come up with it and you remember the name of that person. It's contextual. It's based on how stressed you are, and then how many things are going on at the same time. Things that we can do to test language. For example, we can show you pictures of objects and you have to name them. Or we can give you text to read and we count how many words you read in a minute. Or we tell you to repeat things and we assess how well you repeat, how accurately you repeat, and if you have any slurring of words. We can tell you to write things, or we can tell you to classify words. We can show you a word and we can ask you, is this a verb, or is this a noun, or is it an adjective? So other forms of testing language. And then the space processing. Space processing is something, that we take for granted, but it's very important. We are visual beings, right? So how well can you how aware you are of your full surrounding. If there's a problem, you might tend to ignore one part of your field or of your visual field, or you might have blurred vision, for example, or you might have problems recognizing someone's face. You may also have problems with calculation. That there's some visual spatial function has some mathematical components, so people may lose the concepts of numbers, and they may lose the concept of time, disproportions. But it also can be tested by just copying a figure. Can you copy this diagram, or can you point out in this part where this dot would be? Can you match the dot to this space, or can you solve this multiplication or this division? So those are the things that we will do to test. But at the end of the day, and there's another one. The other one is important. It's mood. It's difficult. This is one of those that is difficult to measure because it tends to be subjective, and we just go by what the report is. Are you feeling sad or not? Are you feeling like life's not worth it? Are you having thoughts of not existing, not being around? Do you have thoughts of feeling all the time anxious and worried about something? Do you feel restless? Do you feel with less appetite? Do you feel like you have problems sleeping? So we just go by the report. There's really nothing that we can do to measure those things. And this is similar to pain, for example. There's no tool that we have to measure pain. We just have to go by what you tell us, and we just believe it and treat it accordingly. But at the end of the day, all these domains that again are very simplistic compared to really the whole spectrum of who we are, all the complexity of our cognition is reduced to these very simple elements that we can track, and it ends up being a paper and pencil test. Basically, you are with a psychologist, and then they ask you questions, they show you pictures, and it's a very simple test. And simple test that takes about an hour, but simple in the means that it doesn't require any sophisticated equipment. It just requires some time, and it has to be in a very quiet environment and without distractions. And the psychologist is just taking notes and marking the answers. And when we do this, we take into account the fact that it's an artificial environment, and you might be nervous about it. You might be not knowing what to expect. And we take into account the fact that some things like if you're anxious about that testing the night before, you weren't able to sleep, that's going to affect your results. If you, for some reason, you were running late and then you skipped lunch and you came over here and you started doing the testing and you skip lunch, that's also factoring. And of course, we factor in the fact that with age, there's some cognitive decline. So when we assess the results of the testing, we compare them with people your age. We have a standard, and this is an important issue because we have very good parameters for the Caucasian population, for African American population, but for the other minorities, Hispanic, Asian, Native American, the definitions are not as good, and sometimes we struggle. When I see Hispanic patients, I struggle because I don't know how to relay the results to the standard, because the standards are derived from a different population, and this is also affected by your educational status, your educational background. So that's also factoring. We might give you extra points if we know that you have lower education. But the bottom line is that this is available. This is something that is going on now, and it happens. We use it a lot for degenerative diseases, but it can tell us whether the problem is due to a degenerative disease or not. It could be related to something like a cancer problem. So I'll give you an example of how we display this. We have what happens in cancer. We know that there are based on these tools, we know that there are changes in cognition that we can track before cancer and after cancer. This is about a year from the diagnosis, and after you make the diagnosis and then you give the therapy, and this is what happens. So you'll see the average score with some variation, and then these are kind of some of big tests that we have. We have a global measure of cognition. This is a test that assesses a wide variety of functions of the domains. But then we have specific domains like verbal fluency and digit span are executive function measures. So these two are executive function. And then we have two ways of measuring memory. So pay attention to the numbers here and compare this column to this one. Don't pay a lot of attention to this SD, but look what happens. Across the board, for all of them, let's take, for example, this one. The number is very high here before cancer, but after cancer it drops 29 to 25. This is just the score. But also the same thing happens to the executive function. For example, verbal fluency is how many words you can tell me in a minute. Verbal fluency. This average, these 34 people, the average was about 11 words per minute, and then it drops dramatically to 6 only after cancer. Memory, how many words you can remember? 5 words here versus 1, drops kind of severely there. And then these things tell you the magnitude of the change. About 1.5 is already bad, but look at this. These are changes of 9 points or 12 points. And then this is an important test for us because it tells what's the chance. This number tells what's the chance that this drop from here to here is just due to chance. Just what's the probability that this is just a chance that happened just by chance, and it's 0 or close to 0, right? So we know there's an effect. The only difference between this and this is that there was a cancer diagnosis and a treatment. So we can measure the changes.
How far after were they measured?
1 year. This is, but depends on the study. Could be 3 months. Could be 1 year. We have data that is far down the road, 3 years or 10 years. So I'll show you some of that. But we can measure this. We know these are objective changes, and we have other tools that are a bit more sophisticated. We can take pictures of the brain, and we can analyze those projections. Remember the connections I showed you that neurons send, the axons? They communicate to different parts of the brain, this spot from this spot. This is a brain kind of look from the side, like this. You're looking from the side. So the eyeballs will be here. So the back of the brain sends projections. These blue lines are the projections. And the red spots are areas that are damaged. So they are, when you have a situation of cancer or cancer treatment, there are areas that are more vulnerable than others to decay or degenerate. And these seem to be right about there and there. These are big spots that serve as big connectors or big hubs that receive a lot of information from all over the place. But they seem to be particularly vulnerable to decay and to show degeneration. And then let me show you what happens in this spot here. This red area here. This is a graph that shows, on this side we have how much integrity you have. So higher number is better, meaning you have more integrity. And it's just a number. 0.34 is high integrity versus 0.29 is low. Meaning that if you're lower, means that you have more destruction of fibers here. So, and these 3 bars represent the integrity at 3 different points. One before the treatment, before cancer treatment, and then 3 months after treatment. You see how there's a drop after cancer, meaning there's destruction of tissue here. But then after 3 years, look at what happens. The integrity goes back again. And in this case, they didn't do anything. The only thing they did was to wait. To wait for people to be studied again. And without doing anything, seems like the brain had the capacity to regenerate and to maintain the integrity that was seen at baseline. And exactly the same picture happens in the back. So it's the same graph, After 3 months, you have decay, but after 3 years, seems to recover. So this is very good news, right? Because it seems like the brain has certain capacity to regenerate. Now, I want to touch on these numbers. The cognitive changes that we saw, that we demonstrated, are very common. About 75, 3/4 of people will show certain level of cognitive change with cancer, associated with cancer. About 35% of people will have cognitive changes before treatment. So that shows that it's not the chemotherapy only, it's not the radiation only, it's the disease itself, it's the cancer itself, or all the stress that comes with cancer. And it's significant, it's not a trivial number. About 1/3 of people who have a diagnosis of cancer already have some cognitive decline. And then this is the question of how much radiation I'm getting and how long it lasts. How long, if I get cognitive changes after therapy, how long they will last? Well, there are studies that show that even after 20 years, you can still detect some changes that are due to chemotherapy. And these are more difficult studies to do because, you have to track people for so long, but there's some evidence that suggests that this is the case.
That seems to contradict the previous slide that showed the recovery.
That is true, and this is why 75% of people will have some decline, but there's variability. Not all of them. There's some people who will have no problems with cognition. So it's not all or none. There's variability, and this has to do with the risk factors that or the protective factors that we talked about in the beginning. Seems to be like smoking, for example. We know that smoking increases your risk of having cancer, but if you smoke, it doesn't mean that you for sure will develop cancer. So smoking only increases your risk, but it's not a causative factor 100% of the time. It's the same thing with chemotherapy. Having chemotherapy increases your chances of having cognitive decline, but it's not for sure that if you have chemotherapy or if you have cancer, you for sure will have cognitive changes. And this is an important concept. There's variability, and this has this is very individual. And then the bottom line, also a very important concept, is even though a lot of people show cognitive changes, some changes reverse with time, and also most people have cognitive changes that are not very severe. Meaning, even though the cognitive changes are there, people can still cope with their daily activities. They can still, manage their bank accounts and shop and manage their finances and drive and keep up with their appointments and keep their normal lives with struggle, with symptoms. But most people can still function. In some cases, though, in a minority of cases, about 8% of people or 10% of people, some patients cannot function well in the world. They may have to, for example, stop working because they're not able to cope okay with their symptoms. So we're seeing here a picture where there is a variability in what the risk is to get cognitive impairment, variability in the duration on the cognitive impairment, but also variation in the severity. And we saw that there's also maybe some variation in the reversibility of symptoms. So the likelihood of improvement may be different. And I want to show you these 6 different strategies to improve cognition that we don't have any solid data on cancer, unfortunately. I think this is an active field of research, and we'll see more, hopefully more in our community. But I'm translating these recommendations from what we do in our patients, which are patients mostly with degenerative diseases. But I think many of these apply, and especially apply in the context of knowing that the brain has kind of a natural tendency to go back to the original state, as I show you in that picture over there. But an important element is nutrition, and one of the important concepts with nutrition is that we prefer people who stay on a steady weight. We don't like people to gain a lot of weight. We definitely don't like people who lose weight. Losing weight is a negative predictor for cognitive decline. So we encourage a steady state weight over time. The diet that has the most scientific backup for evidence that it promotes some protection is the Mediterranean diet. You probably have heard about it, but it's a diet that is low in red meat, low in processed sugars. It's high in green leaf vegetables, high in dry nuts, the good fats, high in omega-3 fatty acids. A big source is fish. So one thing that you can do if you want to go into that vibe is to reduce the amount of red meat that you eat, and then more portions of vegetables. And a feast is a portion, and at least 5 of those. It seems like certain literature says that we are able to eat 10 of these a day, but I don't think that's too realistic. But at least 5, and we don't expect you to get there by tomorrow, but you can gradually increase the proportion of your diet. Now, there are investigational diets and more radical diets. One of them is called the ketogenic diet. That's used a lot in epilepsy. The brain, again, going back to the idea that the brain is very sensitive to energy supply, when you give a supply of energy that is mostly based on fat, the brain seems to treat that very differently and seems to make a lot of these processes more efficient. So the ketogenic diet is a diet that basically removes most source of carbohydrates and basically is composed mostly of fat. It's a very difficult diet to follow, and I prescribe or I work with this diet in pediatric patients, in children with epilepsy. It's very difficult to adhere to it. It's very easy to get out of it because you need to be really creative. I think there might be a big trend or a tendency towards going there in our population in Alzheimer's disease, and maybe this will also leak into cancer related treatments, and we might have trials with this sort of diet. But I think this is good news because we're expanding the horizon and the possibilities that we see.
And I assume you mean vegetable fat rather than animal fat?
Yeah, that's correct. Yeah. Well, no, it is. Yeah. When that's kind of the difficulties. If you go into the ketogenic diet, your options get reduced, and then it becomes boring. Eating the same sort of things every day could be very difficult. So it's a very challenging diet to follow, but seems to have some benefits in the brain. Really, the best evidence that we have so far is the Mediterranean diet. But hopefully we can do more research on it and give more answers. Another aspect is physical activity. This has to be aerobic activity, and then again, we don't have a lot of research to back this up, but we go by the recommendations of the American Heart Association, and we recommend 30 to 45 minutes of aerobic exercise per day, moderate to intense, meaning something that gets your heart going, something that gets you sweating, something that gets you tired, and this has to be most days of the week. It is, again, it's a lifestyle thing, so it's easy to drop it, it's easy to not follow the recommendation. And we have this dose of most days of the week, 30 to 45 minutes per day. We don't expect you to be there next week, but you can increase the dose little by little every week, introducing an extra day of exercise of this intensity. A good strategy is to do it with the supervision of a personal trainer or as a part of a group of friends or a class in a gym. We are becoming more strict about prescribing exercise. This is a good one because apparently the muscles are not there just for mechanical reasons. Seems like every time there's muscle contraction, there's a release of hormones and cytokines and anti-inflammatory agents that seem to benefit the cardiovascular system, the heart, the blood vessels, but also the brain. And exercise in some studies looking at cognitive function seems to benefit especially executive function, that function that is impaired mostly or is vulnerable in cancer. Surprisingly, because these interventions have been tailored to cognitive impairment due to Alzheimer's disease or degenerative disorders, and surprisingly or disappointingly, the exercise doesn't benefit memory that much. It seems to benefit more the processing speed and your ability to pay attention to things and maybe to learn. So this is a good thing that is in our hands. It's something that we can easily incorporate. Now, what if you can do aerobic? What if you can run because you have arthritis, you have pain, or you have some mobility problems? Well, try low impact exercise like swimming or bike or stationary bike, or if you definitely cannot do something with your lower body, try repetition aerobic with your upper extremity. Sometimes we struggle a lot because we have people who cannot move, or they don't know how to move, and the worst case scenario is at least try to transfer or at least try to walk several times, but don't stay sedentary. That's one of the bottom lines here for exercise. And then another point is good sleep. Sleep is very necessary. We spend a third of our life ideally sleeping, and it seems like a lot of the things that we learn get stored, consolidated during sleep. So we have to ensure that we implement all the strategies necessary to help our brain get that rest that it needs. And sometimes this means getting some help from sleeping aids. Sometimes this means treating very common conditions like sleep apnea. Sometimes from overweight, there could be obstruction of the airway during sleep that impairs the flow of oxygen during sleep. And again, I'm going back to that first concept that the brain is very vulnerable to lack of oxygen, lack of nutrients, lack of blood flow. And we can definitely help the brain by getting a nice period of sleep with good oxygen. So if you have cognitive impairments and also have problems sleeping, you can do a lot by addressing the sleep problems first. And just a word of caution here is we can help you sleep better, help you fall asleep better, and help you maintain your sleep with medications. But it's important what medication we choose. Some of the medications that are available may have the side effect of giving you cognitive side effects, which is what we're trying to prevent, right? So it's important to choose the medications that have the least, or the most benign cognitive side effect profile. And it's just a matter of talking to your doctors about it. But you can do things like try melatonin. Melatonin is over the counter, and melatonin is something that your body produces. Melatonin is mostly helpful to induce sleep, to help you fall asleep. But if your problem is that you wake up in the middle of the night and then you're not able to go back to sleep, then maybe melatonin is not the best. You have to look for something else. But before going into medications, it's always helpful to follow what we call the sleep hygiene. And these are a series of habits that help us maintain a good structure for sleep. Going to bed at the same time every day or every night, avoiding physical exercise within hours of falling asleep, avoiding big meals before going to bed, avoiding alcohol before going to bed. Alcohol gives you this paradoxical effect that makes you a little bit sleepy, but then it disrupts sleep, and at 3 a.m. or 4 a.m. you're awake because alcohol disrupts your sleep. So cutting back on alcohol before going to bed, especially, and then exposure to screens. This is something that we see a lot. Exposure to screens before going to bed, watching TV or watching your tablet or watching the computer. The light that emanates from the monitor changes your internal cycles and actually pushes your brain towards sleeping later and later. So the idea is, or the ideal thing would be to reduce exposure to these monitors 2 or 3 hours before going to bed and have a schedule like that. Again, this is one of the most important, it's important, but it's one of those difficult things to do because it's a lifestyle change. And you see, we are talking about in terms of diet and exercise and sleep. These things seem to be pretty effective, but they are hard because the imply changing our behavior, and it's hard to change our behaviors, but it's possible. Another aspect of improvement we've been talking so far, and this is the fourth one, social stimulation. Staying with friends, staying connected with family, doing social events, talking to someone every day. I have patients who live far away and they're kind of isolated, but I encourage you at least give a phone call to someone, talk 10 minutes over the phone to someone every day. There's something about communication, about, we hearing something, processing that information, and then coming up with an answer, and maybe perceiving the facial expression, and keeping that engagement. That is very beneficial, and it keeps the brain active. It's probably, there's more evidence supporting social interaction than evidence supporting Sudoku or the crossword puzzles. That those don't seem to generalize that well. You can, if you do a lot of crossword puzzles, you're gonna get very good at it, but that doesn't mean that you're gonna get good at other functions. But social interaction seems to give that effect. Social interaction can keep your processing speed going, your language going, your memory going, because you're going to push to use all these resources, and it affects the mood part of it. So we know also from observational studies that people who get socially isolated have higher risk of declining. So the worst case scenario is someone who loses weight and is socially isolated. Those people are at high risk of declining. And this is very important. The fifth one is this person here with all these screens, a lot of information going around. So information overload. So what we strategy to improve cognition is to simplify the cognitive overload, to be very selective at what we really want to learn and what we really want to pay attention to. The brain is different from muscle. If you want to increase your muscle mass, what do? You go to the gym and then you start going after it, right? Pumping iron, doing a lot of repetitions, and then eventually you develop muscle mass. But the brain doesn't work like that. If you give a lot of overload to the brain, memory tests, and then a lot of memory exercises, that only makes things worse. That's just going to overload the system and make things slower. Think about a computer that is having problems processing information. If you download a new program while the computer is already struggling, that's just going to make things, it's going to crash. So you want to simplify information. It's not very useful to say, come on, tell me the date. I know you know the date. Tell me what is the date? You told me before. What is it? It doesn't help. The best thing is, this is the date, this is the information, here's the information. Take notes, use your pad, and always carry a pen with a pad or your electronic device. Record your itinerary, the things to do for the day. It's okay. It facilitates. It's an adaptation, and it helps. And in that way, you don't have to worry about, what is the name of this person? You already know because you have it here. You can look up. You can use a little bit of humor. I know it's embarrassing sometimes to have those leaps of not remembering someone's name, but if you make a little joke about it, you don't have to worry about it. It's better to say, I'm so bad with names. I'm sorry. It's the age. But tell me your name again, and then in that way you don't have to be worrying the rest of the party about, I don't want to address this person because I forgot their name, and it's okay to. It's also okay to use your partner as a memory aid. You don't have to carry all the information yourself. You can split and conquer and divide, and it's okay to help each other. But the bottom line is simplify this. Make sure that you pay attention one thing at a time. For example, this is a very common thing. You're talking to someone, and that someone is telling you something, and that is telling you something very important, and you're already thinking about what you're gonna do after you finish the conversation. And of course, you don't capture any of that what the person said, but really make a conscious effort to concentrate and pay attention to what you're doing. And then you had a question about this, I think. The mental fatigue. So this is related to the mental fatigue. If you are overloaded with information throughout the day, at the end of the day, that's why you have that fatigue kicking in, and that's mental fatigue, not the physical fatigue. The physical fatigue can definitely come from the effects of radiation and the chemotherapy and the disease directly to the tissues, but the mental fatigue is you can address by doing this, by simplifying what you're going to learn, what you're going to be thinking of during the day. And then the last part is the medications. Unfortunately, we don't have medications to improve cognition. And there are medications approved for Alzheimer's disease that sometimes I've seen people use them in other contexts like chemotherapy and cancer-associated cognitive decline. But we don't have a lot of evidence that they work, and if they work, it's maybe anecdotal, and maybe that it works for that particular person, but if we try to use it on a different person, it may not work. We don't have good treatment, but we have medications that can address collateral problems like the sleeping pills. We can give you a sleeping pill and make things better. You can maybe rest better, and that indirectly will help your cognition. We can also give you medications to treat your mood. I mean, fortunately, when you have a difficult scenario like cancer, you may have cognitive problems from it. You can also have mood issues, anxiety, depression from it. But fortunately, you don't need to have cognitive decline and mood problems. Fortunately, we can deal with mood problems fairly well with interventions, medications, or with psychotherapy. So we can give you medications for those things, and indirectly, again, that helps your cognition. And of course, all the medications to keep you healthy, the medications that we know are good for the cardiovascular system, especially if they are indicated. If you have diabetes and you have hypertension, if you have cholesterol, make sure that you're properly treated and that you take your medications. And that indirectly will also put you in a better scenario to cope with your cognitive symptoms. Maybe in the future we'll have some medications that will be specially tailored to increase and boost cognition. You may have heard about the nootropic agents, or memory boosters and vitamin supplements, and pharmaceutical or nutraceutical agents, naturalistic treatments. All of these things, the way I approach this is we don't have evidence to support against or in favor of it. My only recommendation is if you decide to marijuana, for example, we don't have evidence, but if you decide to use any of these treatments, just 2 words. One of them, make sure you tell your doctor, so if there's a cognitive change, the use of that medication is factored in when they do your evaluation, because we're still learning about what the effects can be. But it's possible that valerian is the great next thing to improve memory. So, but we would like to keep track of that, and we are being more careful about keeping track of all the nutraceuticals and all the over-the-counter medications that our patients take, just to keep track and to learn more about them. And one more word about that. But the other aspect of it is when you use these over-the-counter medications and these nootropic agents that are commercially available, my concern is that it's very easy for the patient to become vulnerable and to be victim of basically scam, because you're going to hear claims that this is the best treatment for your memory without a lot of scientific backup, and then you're just going to be throwing money at it without necessarily getting a benefit. Plus, I've seen lists of 30 vitamins and 30 different pills and tablets that just makes things harder to keep track of. That's another medication that now you have to remember to take and to sort, and I take this one. Is this in the morning or in the afternoon? So without having the evidence that they actually work, I would just caution you to keep your doctor informed, and maybe think that it probably is better to exercise and to be out with your friends. And we used to say before, an apple a day keeps the doctor away, right? Now we say, go buy an apple with your friend, or paint an apple, or use your Apple device. That's probably more useful than the nutraceuticals. However, we are pill doctors, so we are interested in developing treatments, and this is from the clinicaltrials.gov. It's probably 3 months or 4 months old, but you'll see that all these interventions here that you see, like acupuncture and methylphenidate is a drug that is already used for attention deficit disorder, ADHD, or there are things like cholesterol medications. Ritalin, yeah. But cholesterol medications, look at that. All these are being used in clinical trials right now to treat cognition changes after chemotherapy. So if you're really interested, you can go to Denmark and get a treatment on systematic like exposure. Well, the bottom line is the community is really paying attention to this. And I hope that our own community in San Francisco will have access to one of these trials soon. My recommendation is if you're interested in a treatment, try to do it in the context of research, as opposed to just paying for a drug that that is expensive and you don't even know if it's going to work, and no one is going to be monitoring for your side effects. But there's more attention to this. We are recognizing it more. We know it's a real thing. We know it's just a psychological effect. We know it's an actual change that happens in the brain, and that it can be very annoying. And we want to pay attention because I feel that it's potentially reversible and can get better. So if you have cognitive changes right now, you feel you're not at your baseline, and you feel the symptoms are severe enough and that you don't feel comfortable, the best thing you can do is talk to your doctor about it. Talk to your primary care doctor, your cancer doctor, and tell them, I would like to have an evaluation. The best person to address these sort of changes is a neurologist or a cognitive, especially a cognitive neurologist. And here we have, in our community, we have a good number of neurologists that can address this placement. This is important because of 2 reasons. Most of we are worried about cognitive changes that occur in age, right? The thing that is always in the back of our mind is this Alzheimer's disease. It's a very common condition. About after age 65, about 1% of people will have or will develop symptoms of Alzheimer's disease. By age 85, about 50% of people will have changes in the brain that are related to Alzheimer's disease. Not all of them will have symptoms, but it's very common. So for us, it's very difficult to differentiate sometimes, is this an Alzheimer's disease or is it just an effect of chemotherapy? And sometimes the only way to tell is to follow longitudinally, just to bring you over time several times and see your pattern of cognitive changes and see your pattern of decline and progression. And we have tests for Alzheimer's disease now. We can also separate. So if you have concerns now, the best thing you can do is to talk to your primary doctor and say, I'm having memory problems. Can you refer me to a specialist to address this?
So I know with an MRI you can see demonstrable biological changes with Alzheimer's. Is it the same with post-cancer or cancer-related cognitive decline?
You can get hints, but they're not perfect measures. And even for Alzheimer's disease, the MRI is not telling for sure. Only when it's very striking, we can convince ourselves. But sometimes the brain looks normal in the MRI, and the person still has Alzheimer's disease. So you require other more elaborate tests to be able to tell. Unfortunately, for cancer-related therapies, we don't have that. We don't have a blood test that tells, oh yes, this is a specific change due to cancer or to chemotherapy. We don't have a scan that is just due to that. Sometimes the changes in the brain that are caused by the drugs, the chemotherapy drugs, are similar to the ones that are caused by Alzheimer's disease. And sometimes it's very hard to tell, and it's just a matter of keeping people, tracking people over time and see the patterns. But the bottom line is that we can help. We can help tease apart, and one of the tests is definitely an MRI or a scan of the brain to be able to tell.
You talked before about tests where you had a baseline. Assume that somebody doesn't have a baseline and they have post-chemo cognitive impairment. Is there some way that you can assess that without the baseline?
Yeah, one way is to look at the pattern of cognitive decline. In chemotherapy-related changes, is mostly executive. The deficits are in the executive domain and some memory. It's a little touch of visuospatial, but it's mostly executive memory and then the little tail of the visuospatial. Versus Alzheimer's disease, where it's all memory at the beginning, and then over time you get some executive dysfunction in language too. But it becomes kind of global all over the place. So that's one way of telling, looking at the pattern, and this is where the neuropsychologists help us really a lot. But the other way is to keep track of you over time. Even if we don't have a picture before, we can still get a picture, prospectively in the future, and we can. What we see is that Alzheimer's disease tends to drop no matter what we do, and chemotherapy kind of stays the same and sometimes improves. So that's a very good question. But again, this is an example that we can help and we are able to tell. But the other aspect of it is, I said there were 2 points. The second point is that we have been surprised. Sometimes I mentioned this before. We received referrals from the cancer doctors who said, we've been following this patient, and we know this is a patient with chemotherapy-related cognitive changes, but this is too severe, and it's kind of getting worse, and we just want to make sure that they don't have, Alzheimer's disease. And then we do our magic dust of neurology, and we actually find out that yes, they have cognitive changes due to chemotherapy, but also they have Alzheimer's disease. And those are very rare cases, very unfortunate cases, but this is, I think, why it's important to just not assume that it's just age or assume that it's just the chemotherapy. If it's annoying enough, it's worth taking a look at it, and it's worth implementing some of the recommendations that we talked about.
But they're the same, whether it's cancer-related or Alzheimer's. The recommendations are the same.
So far, yes.
So there's really not a huge advantage to distinguishing from a therapeutic point of view.
You're totally right, and I think, in my point of view, for us it matters to tell the difference because it helps to plan. If I tell you that there's Alzheimer's in the picture, maybe your approach to your resources will be different. You start engaging your family and you start planning for it, right? But also, if I tell you there's Alzheimer's disease, we have trials for Alzheimer's disease. We have potential interventions that could help. I hope that in the future we'll be able to be in that situation of if we tell you this is just cancer, that's the problem, cancer-related treatments. Maybe we can route you to the right therapies, the right clinical trials, or maybe give you just a picture of what we expect to see, and that's a different kind of preparation that you have to do for the future.
I have one last question.
Yes.
Do you have any data about meditation benefiting?
Yes. We use meditation a lot, and meditation is good when the picture is overwhelmingly mood related, and sometimes it helps with certain parts of executive function. It helps mostly to address the mood issues, but I can tell you, for example, that our patients with Alzheimer's disease don't benefit from it. It's very stressful for them to try to, picture themselves in a quiet environment. It's very hard, and it's more distressing, really. But if you have an executive problem related to a systemic metabolic issue like cancer-related chemotherapy, it's probably going to help. And I've seen some effects of this with other medical conditions that are not dementia or degeneration or cancer, but I have to do, for example, with a medical condition that causes mood changes and executive problems, and meditation actually helps. Mindfulness-based stress reduction. There are a few programs here. I think the Osher Center runs a few of those, and I refer patients to that program.
And we have a free drop-in every Monday at 1:30 for cancer patients and caregivers.
And it's one session or
an hour long every week, every Monday, 1:30 to 2:30 at the Osher Center.
Well, that's a good resource for sure. Yeah. But things that have to do with mind-body connection, like Tai Chi, yoga, those seem to be beneficial too. But they don't solve the memory problem. They solve the mood executive components of it.
When you had the slide up for the mitochondria and myelin, were you saying that that physiologically the chemo, cancer, radiation affects those areas the most in the brain?
Yeah.
Okay.
Those are two elements that are vulnerable. Maybe there are more elements. You know, a very common element that we think of is the actual DNA, you know, the genetic material. We know that some of these cancer drugs can interfere with it. But for the purposes of the brain function, the mitochondria and the myelin are key for explaining why the symptoms happen. And also give us hope that these are elements, you know, neurons don't regenerate.
Right.
But these elements within neurons can have a potential to, you know, to divide and to renew. And I think that's what we should exploit in our treatments. You know, there is animal evidence that exercise, for example, increases neurogenesis in the hippocampus. That is not paired with improvement of cognitive function, but at least in animals, there's evidence that interventions like exercise can regenerate neurons in certain parts of the brain. Not only there's another.
ENF is the intermediary.
Yeah, I think in those things we're actually interested in looking at those, measuring them to be able to tell, for example, if someone has cognitive decline after cancer or chemotherapy, seeing if those hormones or these chemokines are elevated or changed in those people, higher or lower, and maybe those could be targets for the future. These molecules that are good for the regeneration of brain tissue. Yeah.
Yes, sir.
So this is a very good and important question. I often see referrals that come from, you know, the primary care doctors, and for many years they have attributed the cognitive changes to menopause, to being on hormone replacement therapy, and the other things, you know, depression and stress. Those are the common ones. But none of those, there's no evidence that any of those cause cognitive changes that are so severe to produce impairment of function.
The suppression of estrogen does.
So,
Doesn't
at least in our population, this doesn't seem to be an effect. And I know that longitudinal studies in people who are interested in looking at the effects of the aromatase inhibitors in combination with chemotherapy, they've tracked the effects of these medications, but they don't seem to have a very particular differential effect. I think the strongest evidence comes from the classical chemotherapeutic agents, you know, the earliest regimens. But the aromatase inhibitors and even the hormone replacement, you know, even not in the context of cancer, there's really no strong evidence to suggest that they have an impact. And that's why one of the dangers I talked about in the beginning is to attribute the cognitive changes to these common things, stress and menopause and depression. None of those can cause the severity of symptoms that we see, like the drops that I show you in the graphs. None of those will cause a drop like that in this testing. I think it's possible. I think this is a very important question too. Even though hormone changes don't seem to have over time or over long periods of time an effect on cognition, acute changes is different. Any sort of acute medical change in medical status overnight, meaning or over a few days, that can be severe enough for the brain not be able to adjust. And drops like that in any sort of hormones, it doesn't have to even be a reproductive hormone. It could be thyroid. It could be your calcium levels, your sodium levels, your electrolytes. If they drop overnight, the brain doesn't adjust that easy, and they definitely can cause. But those changes are very evident. They're very dramatic. They occur very rapid, and if you normalize, you know, the hormone levels, they get better usually. But this is very important, and it's important also because the pattern, the cognitive pattern they show is very similar to what we see in cognitive changes. They just happen more dramatically, quicker, but they affect executive function mostly. Yeah, very good point.
Okay.
Gabapentin is one of the ones that we try to avoid, but sometimes we can because that's the only thing that is useful for pain. We try, if it hasn't been tried, we try to go to alternatives like Lyrica or duloxetine or some other interventions, but sometimes we just have to, make a compromise and maybe reduce the dose, or just have that idea that, you can have your pain treated, but you're going to have the side effects from the medication. Unfortunately,
And they don't get better the longer you take it. You don't adjust, at least.
that's a hard one. But I don't think we have a solution. We have this compromises sometimes, minimizing the dose, and I've rarely seen someone who depends on gabapentin for pain control that is able to get off to control the cognition. Most of the times they need to stay on it because it's better to have the pain control, right? Yeah, that's a big issue. That's a big problem. So that's, if you combine that with the other effects of the cancer, that could be a bad combination. So forth. Yeah, I think we need this in UCSF. We need a strong group, a strong collaboration between cancer and the cognitive center to investigate, to understand this better in our population, and to be able to come up with treatments. We definitely need to study this. We need to partner. We won't be able to do it ourselves in the memory clinic, and I think you guys are too busy actually treating people and curing people that we can help by keep paying attention to the memory and the cognition. Yeah.
Would that be something that you think a patient could suggest to their oncologist, that they would like to have a pre-treatment test?
I've had that.
Oh, okay.
I've had that, and mostly it's not the patient. It's not coming from the patient. I think it's coming from the doctors. That they want to make sure that there's no baseline problem.
Yeah.
Or the other scenarios when the cognitive deficit after treatment are so severe, they're not going away. They're getting better. We're worried there's something else going on. But I think that's a very reactive approach. I think we need to be more on the proactive side and have baseline for everyone as part of a standardized approach, and be able to track. And hopefully one day we might be able to, even before treatment, detect who is at risk of cognitive decline and offering them interventions beforehand. That's kind of the idea, but hopefully.
That's great. Well, I know it's the time now, so I just want to thank Dr. Rojas for being here. Thank you so much. That was so informative. And this was so well attended. I'd love to do this again.